Dr. Broadmeyer Fleming up to introduce Mia, and I will get her slides up.
All right. Thank you all. Some of our work that Mia is going to share with today stemmed from us receiving a team science grant through the Simmons Cancer Institute, which was made. So this part of this data was started because of findings that we found through that team science grant. And so the supporters of the Cancer Institute I'm very thankful for everything. And last fall, my father was treated by the physicians here at the Cancer Institute. So I didn't just get to see my physicians alongside of myself as colleagues, but I also got to trust them with the care of my father for his battle with cancer. And so I can't thank Dr. Khan and Dr. Macharnik enough for taking such excellent physician care. So this really did set in my mind also that our Cancer Institute is really top-notch and is the jewel in our crown for the School of Medicine here. But now let me tell you about my awesome student. So Mia came, I selected her application not just because of her phenomenal scores, but I will say it stood out because she's from Murray State University and from Pleasant Plains, which there's a connection there later. Mia is from Springfield, but what I learned is if you're from the west side of Springfield, you go to Pleasant Plains High School. So she's not from Pleasant Plains, but attended that high school. She does currently attend Murray State, which I had my niece just graduate from Murray State this last May. And Mia is attending Murray State, starting her senior year now with her degree in biology and pre-medicine. And what she wants to do with this, which I tried to dissuade her a bit, is to pursue a career in medicine and then fitting for my laboratory as a discipline in obstetrics and gynecology. I always try to sway my students to be MD PhDs or PhDs and not forget that much need in our medical field for physician scientists. She's joined today by her parents, Brian and Tara, and her younger brother, Seth. And so Mia and I have several degrees of connection that we never knew about. We now think between the two of us know everyone in Pleasant Plains, Illinois, which is a town of 800. And I just learned the thing that capped it all out, making this really a true, strong connection, is that her family are Packers fans, which is very rooted in my family history also. So Mia, please come up and share with everyone the research project that you undertook this summer.
Hi, good evening everyone. So my presentation is over the expression of steroidogenic enzymes and their correlation with inflammation in patients with gynecological cancer. So endometrial and ovarian cancer are two of the most common gynecological cancers. Endometrial cancer occurs when cancer cells originate in the endometrium, which is the inner tissue that lines the uterus. And ovarian cancer occurs when tissue cells originate in the ovaries. So both of these cancers have increasing incidence rates and also low survival rates when caught in advanced stages. For example, endometrial cancer, when caught in stages 3 and 4, have about an 18% survival rate, where ovarian cancer is just slightly higher at 30% in those advanced stages. So you may be wondering, why are they caught in these advanced stages? One reason is, to date, there's no effective screening method for early detection of these cancers. And also, as you can see, they have really vague symptoms such as bloating, abnormal bleeding, and weight loss. This can lead to just a delayed workup, where eventually a provider will evaluate their serum tumor markers, do imaging, and complete a surgical biopsy to confirm their pathology. But problems arise in patients who are poor surgical candidates, because if they undergo surgery, it could end up in an unnecessary morbidity. But if there is a malignancy, delaying the surgery and delaying treatment can also negatively impact survival. Estrogen is a hormone that aids in normal cell function, and it also regulates the reproductive system. Estrogen and progesterone are both hormones that usually work together to prevent the lining of the uterus from over-thickening, as you can see on your left. Estrogen and progesterone also help to regulate the ovarian cycle and ovulation. But estrogen can cause problems when it's unopposed during the entire menstrual cycle. As you can see on the right, you can see the endometrium is abnormally thick, which is called hyperplasia. Another problem with unopposed estrogen is when there's a tumor nearby and cells are proliferating at a rapid rate. When unopposed estrogen is nearby, it can cause those benign cells to turn into malignant cancerous cells. So this is a problem. So there are three main forms of estrogen in the body: estrone, estradiol, and estriol. And there are also three pathways that estrogen metabolism can take. CYP1A1 is an enzyme shown in green that promotes the 2-hydroxy pathway. And the metabolites created in this pathway are eventually secreted in the urine, and it's considered the safest pathway of estrogen metabolism. CYP1B1 is an enzyme, and it's shown in blue in the middle, and it promotes the 4-hydroxy pathway. This pathway is considered dangerous because it's the most genotoxic pathway, meaning it can damage our DNA. Whereas the CYP3A4 enzyme, shown in red, promotes the 16-hydroxyl pathway. And this is also considered a dangerous pathway because it creates the most estrogenic metabolites, meaning it can lead to unopposed estrogen and tumor development. So who does this impact? Unopposed estrogen impacts women who are at high risk for endometrial and ovarian cancer. So we know that changes in estrogen signaling can cause cancer. So we want to see if inflammation is the cause of these changes in estrogen signaling. Past studies have shown that Th17 lymphocytes and cytokine IL-17As in ovarian tumors are upregulated, meaning there's more of them. And another study has also found that there's an association between Tregs and Th17 cells producing IL-21 and IL-22 cytokines in ovarian cancer patients. So what are these cells? Th17 are a type of T helper cells, and they're pro-inflammatory, whereas Tregs are T regulatory cells, and they're tolerant cells that inhibit T cell immune activation. So when there's more Th17 cells than Treg cells, that indicates that a patient is inflamed and has inflammation. So our goal of this study is, if cancer causes inflammation, does inflammation affect estrogen signaling? We also want to know if a patient's immune status, which is their ratio of Th17 to Treg cells, will predict estrogen signaling in these patients with these gynecological cancers. So a FACS analysis showed us that women with endometrial and ovarian cancer both have a much higher level of Th17 cells compared to Treg cells on not only their day of surgery, but also at all of their post-op appointments. So now that we know that these women are inflamed and these immune cells are present, we want to know what's creating this inflammatory environment. So we look to immune mediators. The immune mediators we chose to study were cytokines, because cytokines are what inflammatory immune cells produce to create an inflammatory environment. We compared endometrial cancer and ovarian cancer to two different control groups. Endometrial cancer patients were compared to control groups of healthy women, while ovarian cancer patients were compared to control groups of women with benign pelvic masses. As you can see, both endometrial and ovarian cancer patients had elevated levels of inflammatory cytokines. So this tells us that these women are indeed inflamed, and the inflammatory immune cells as well as the inflammatory cytokines are contributing to this inflammatory profile. And this leads to the project I worked on this summer, where we hypothesized that the development of endometrial cancer or ovarian cancer promotes inflammation and alters estrogen metabolism, promoting tumor growth and metastasis. We wanted to see that if the expression of steroidogenic enzymes CYP1A1, CYP1B1, and CYP3A4 affect estrogen signaling. We predict that the enzyme CYP1A1 will be downregulated in women with these gynecological cancers because it promotes the safest pathway, whereas we predict the enzyme CYP1B1 and CYP3A4 will be upregulated since they promote dangerous pathways. For our study, we included women who were over the age of 30 years old and also presented for postmenopausal bleeding, unspecified pelvic pain, and/or suspected of endometrial carcinoma, adnexal mass, ovarian carcinoma, or benign gynecological disorders. We excluded women who had previous pelvis or abdomen malignancies, who had breast cancer in the last 5 years, or are currently pregnant or trying to conceive. We first approached patients at pre-op appointments where they were able to complete informed consent in the enrollment process. On the day of surgery, we collected benign and malignant tissue, where we were able to process that in our lab. We were then able to take this tissue and extract RNA from it. This RNA could then be used in reverse transcription to synthesize cDNA, also known as complementary DNA. We could then undergo the CNA in qPCR, where we could measure the expression of our targeted genes, CYP1A1, CYP1B1, and CYP3A4, as well as our endogenous control gene, GAPDH. For the expression of CYP1A1, we found that the relative control level of endometrial cancer tissue was significantly higher than compared to its control tissue. This is not what we expected, but we think this may be due to such a high amount of estrogen in this tumor tissue that it needs to promote the 2-hydroxyl pathway to secrete some of that estrogen metabolites in the urine. Whereas with expression of CYP1A1 in ovarian cancer tissue, the relative fold level was significantly lower than its control group, and that is what we expected. For the expression of CYP1B1, we found that the relative fold level of endometrial cancer and ovarian cancer tissue were both significantly lower than their control groups. This also isn't what we expected, but we think this is due to the tumor tissue protecting its DNA from the damage, so it's downregulating that 4-hydroxyl pathway, that genotoxic pathway. We also wanted to see if there was a correlation between a patient's immune status, which is their Th17 to Treg cell ratio, and their estrogen signaling through the enzyme expression. The only correlation we found was in the enzyme CYP1A1 in endometrial cancer patients, which you can see at the top left. In conclusion, we found that CYP1A1 levels were much higher in endometrial cancer patients, but lower in ovarian cancer patients compared to their respective controls. We also found that CYP1B1 levels were lower in endometrial and ovarian cancer patients compared to their respective controls. We also did measure CYP3A4, but we had little to no expression in our tumor tissue. And when comparing estrogen signaling and inflammation, we only found a positive correlation between CYP1A1 and inflammation in endometrial cancer patients. Future work of this project include analyzing additional inflammatory metabolites such as arachidonic acid and prostaglandin E2, and to also measure levels of estrogen metabolites in the blood and the urine. I want to thank everyone up on this screen, and I also want to thank everyone here in the audience today. I've had an amazing summer. I got to learn so much, and I hope tonight I was able to help you guys learn a little something too.
Questions for Mia?
So do you still believe that endometrial and ovarian cancer are inflammatory cancers, and maybe you just haven't found the right markers to track?
I think they still are. We found the inflammatory cytokines in cells. I think we just found that maybe inflammation doesn't have as much of an effect on estrogen itself. Maybe it's contributing in some other way. Yes.
What was the reason you chose estrogen over progesterone?
That is a good question.
This is when I sit in my students' defense and I'm like, I'm not on it.
I think the reason why...
It's okay.
No, it's a good question.
It's an excellent question.
Thank you.
I didn't hear the question. What was that?
She asked why we chose to study estrogen instead of progesterone.
So we know that these two cancers are estrogen-related cancers. Estrogen is most of these women are postmenopausal, and so they should naturally have lower levels of estrogen. So any estrogen that they are producing is typically unopposed, thank you, because the ovaries are no longer functioning. These women are pretty much in a reproductive senescence period. So any estrogen that you're getting or proliferation, target, growth factor is going to stimulate these cells to take off. These cells also have an upregulation of estrogen receptors on them. And so if the hormone is going to be targeted, it's going to be that one.
So these particular cancers, estrogen is
Estrogen.
predominant.
Estrogen receptor is the predominant hormonal receptor, yes. I could have probably led with that. This is why I don't answer the question.
That's exactly what I would have said.
Yeah.
Mia concurs,
Thank
right?
you.
Thank you, Mia.